Hello and welcome to the latest installment of the Health Storytelling Author Q&A series for this semester, spring 2025. I'm Maryn McKenna. I'm a journalist and author and senior fellow in the Center for the Study of Human Health at Emory University, and I'm the curator of this series, which makes me your host as we undertake our latest set of author conversations. In a moment, I'll introduce you to my guest, Dr. Adam Ratner, professor of pediatrics and microbiology at the New York University Grossman School of Medicine, and his incredibly timely new book, Booster Shots: The Urgent Lesson of Measles and the Uncertain Future of Children's Health. But first, let me tell you about this series. At least once per month, during the academic year, we invite writers whose journalistic or academic books examine health, the science and history of health, and health's intersection with society. This series of conversations is sponsored by the Emory Center for the Study of Human Health, along with an array of fantastic co-sponsors that we are so grateful for. This spring, those are the Georgia Center for the Book, a local affiliate of the Library of Congress, which stages very frequent public conversations with authors, illustrators, poets, and others to bring the news of new books to the public. And also Emory's Center for Public Scholarship and Engagement, which creates opportunities for faculty, staff, and students to share ideas with local and global audiences, and the center's new Ideas Festival Emory, which launched last September on Emory's Oxford campus and will return this coming October with an amazing lineup of speakers. And one special co-sponsor for our next event in March, the amazing Atlanta Science Festival, which sponsors 2 weeks of events that bring science to the public. I'll tell you more about that in a minute. So let me tell you who's appearing in this series, which is live streamed on YouTube, LinkedIn, Facebook, and Instagram, and archived on YouTube, where there are now 5 years worth of interviews with authors of amazing books. Take a look. You already heard about Adam Ratner and Booster Shots, and I'll tell you a bit more in a sec. Booster Shots was published by Avery just 2 weeks ago. In January, we heard from Johns Hopkins Associate Professor Caitlin Rivers with Crisis Averted: The Hidden Science of Fighting Outbreaks, published by Viking. On March 19th, we'll be joined by award-winning science writer and New York Times columnist Carl Zimmer with another brand new book, Airborne: The Hidden History of the Life We Breathe. It's Carl's appearance that is a co-production with the Atlanta Science Festival, and we are very thrilled to partner with them. And finally, on April 16th, Emory professor Jaap de Rude with Doctors by Nature: How Ants, Apes, and Other Animals Heal Themselves, from Princeton University Press. So one final note, this is a live event. You can interact with us, and we encourage you to do that. If you want to ask a question, comment on any of the platforms where you are watching us, and our producer, Stefan Kaplan of Spinit Social, will make sure that we see what you've said, and I'll pose your questions to Adam. Do note that I'll turn to your questions in the second half of this 60-minute live stream, but you can put your questions in any of the comment boxes at any time. So now let's turn to our book and guest. Dr. Adam Ratner is a professor of pediatrics and microbiology at NYU Grossman School of Medicine. He's also the director of the Division of Pediatric Infectious Diseases at Hassenfeld Children's Hospital and Bellevue Hospital Center. And it's important to note, he is speaking in a personal capacity tonight and not on behalf of any of his institutions. He leads a research group, mentors students and trainees, and he's chaired grant review panels for the National Institutes of Health. He's active in science communication and science publishing. His writing has appeared in medical journals, including the New England Journal of Medicine, the Proceedings of the National Academy of Sciences, and Pediatrics. He's the editor of a major textbook of pediatric infectious diseases, and he's a frequent commenter in the media about children's health and vaccine preventable diseases. We have some serious things to talk about tonight. It is an incredibly important time to talk about measles. Measles is an almost completely preventable disease, as you'll hear. 2 doses of the vaccine confer 97% protection against it. And yet, right now, there is a growing measles outbreak in West Texas that is currently at 124 cases, has leaked over the border into New Mexico, and has exposed people on college campuses and at a very popular highway rest stop. And this morning it was announced that that outbreak has racked up its first death in a young child who was not vaccinated. Last week, the Centers for Disease Control and Prevention reported that weekly cases of measles are 5 times what they were last year, and that the disease is occurring not just in Texas and New Mexico, but in Alaska, California, Georgia, New Jersey, New York City, and Rhode Island. So against that backdrop, Adam, welcome to this series.
Great to be here. Thank you for having me.
Thank you so much for coming to talk about this incredibly important topic. So I like to begin by asking people how they came to do the books that they're coming to talk to us about. Tell us a bit about your background and how you came to this interest in measles.
So I am a pediatrician and a specialist in infectious diseases. And I spend most of my time taking care of hospitalized children with infections. And in 2018 and 2019 in New York City, there was an outbreak of measles, and it was a large one. It was, by the end, it was a multi-month outbreak. By the end of the outbreak, there had been about 650 cases in the city, in mostly in cloistered communities in Brooklyn, and there was a linked outbreak in a county north of New York City that had fewer cases, but still, I forget the number, but it was a significant number of cases. And you wouldn't think that that would be such a sort of paradigm shifting thing for me, but that outbreak was a moment of realization, because I had spent my career to that point, which was 20 some odd years of doing this, taking care of kids, seeing some diseases where new vaccines came in and I saw them go away. But there was this whole group of diseases, measles being one of them, that the generations of pediatricians before me had to deal with, and that I really didn't. I had seen scattered cases. I saw a case of measles in a returning traveler. There was a small cluster in northern Manhattan when I worked there. But I went from that over the course of 20 years to seeing 4 or 5 cases of measles a day. And some of those kids, they were all miserable, but some of those kids were very, very sick, and they ended up needing our highest level of care. They were in our intensive care unit. They were on ventilators, some of them. And we were very fortunate that no one died. But it was eye-opening, because it made me realize that the progress that we've made in preventing childhood suffering and childhood mortality is fragile, and that it requires vigilance. And so I started to dig into the history of measles at that point to sort of contextualize what I was seeing. And again, that was 2019, and we all know what happened next. So I had been thinking about putting together a book about measles, and then all of a sudden I was in a situation where I and all of us were dealing with a brand new disease, and with communicating with people about public health measures and about vaccine development and fear and all of these things that I felt like were issues that were presaged or foreshadowed by what we had seen in measles. And that kind of changed the direction of the book, but it really solidified what I wanted to do.
So we will talk about COVID, but we're going to do that toward the end of the conversation.
Great.
I feel like we have to start with this Texas outbreak.
Yeah.
124 cases to this point. Tell us what you know about this.
Yeah, I want to start by just taking a second and saying that today is a sad day. I mean, a child died of a completely preventable disease. And whatever else happens in this outbreak, and I hope it's over soon. And even if there are no more deaths, even if all the kids who are in the hospital now are get out of the hospital, and I hope that they do, this is a tragedy. It's tragic. It is preventable, and it is senseless. Um, you know, Childhood can be dangerous, and there was a time not that long ago. You look back a century, and childhood death was common, and it's not common anymore, at least not here. And anytime it happens, I think we have to reflect on, was there anything that could have been done? And in this case, the answer is yes. So, in terms of the mechanics of this outbreak, we're up to about 124 cases on the Texas side of the border. There is a linked outbreak on the other side of the Texas-New Mexico border, because this is a Gaines County abuts the New Mexico border. So in Lee County, the last number that I saw was 9. It may be more than that now. There have been a significant number of hospitalizations. I think it's almost 20, and then as of today, this one death. The outbreak started in a Mennonite community with a very low vaccination rate. Gaines County in general is a county with a low kindergarten vaccination rate, a high level of voluntary or non-medical exemptions from vaccine requirements in school, and that kind of setup is a situation where a measles outbreak would be expected to happen.
I not very many people know this about me, but I actually spent part of my life in Texas. I went to high school in Houston. Gaines County is very far away from Houston. It's almost as far as you can get in Texas, but I do know where it is, and that it is, as you say, up against the New Mexico border, not very well populated, and with several discrete demographic groups. And that makes me think that, it seems that when measles recurs, conditions like that often underlie the outbreaks, that they're in a very defined place. They're in a particular county or a particular school or a particular demographic or religious group. But in reading the book, I think you would argue that it's not just that measles pops up in those particular areas, but that there are circumstances that link all these occurrences. Am I right?
Yeah, I mean, I very much see echoes of what we saw in 2018 and 2019 in Gaines County, and you're talking about Brooklyn, New York, which is very densely populated versus somewhere that is not densely populated. And there are echoes of what happened with the Disneyland outbreak in California in 2015 as well. I think what happened here in New York was it was against a backdrop of a very high vaccination rate in New York City. So the kindergarten measles, mumps, rubella vaccination rate in the city at the time of that outbreak was 97 to 98%. So it was above the 95% threshold that we usually use to think about whether a measles outbreak could possibly occur. So I think most people would have looked at the city rate and just skipped right over New York City and said, okay, they're good. But we weren't good, because there were areas of the city where the rate was 100%, and then there were little tight-knit communities where the rate was 80%, and that's where the outbreak happened. And that's what we're seeing in Gaines County. It's not against the same backdrop of population density, but Texas as a whole, the MMR vaccination rate across the state, it's not 95%, but it's like 94 or so still. And so you might be forgiven for saying, okay, Texas may not be the next place for this, but there are these clusters, and it's not just in West Texas. There are clusters around, in the eastern part of the state as well. But that's where you see these outbreaks. And I had someone ask me just in the last week, well, where is measles hiding when it's not here? And, is it kind of always with us? And the answer is no. Like we eliminated measles from the United States, which doesn't mean no cases. It just means no ongoing spread. But there's always the danger of importation of measles from somewhere else. And so these outbreaks are often linked to travel. You have someone who's unvaccinated, they travel, they get exposed, they come back home, they develop measles. So that's case one. And then sometimes you have another case or two in the family if there are unvaccinated people in the family. And then where the paths diverge is what the rate of vaccination is in the community around them. If the rate is good, if it's over about 95%, it ends there. It's you've got your little family cluster, and then nothing else happens. If the rate is like it is in Gaines County or like it was here in the Brooklyn communities, it can pick up steam, and you can have second and third and fourth generations of spread, and that's what we're seeing now.
You have a really fascinating story in the book that's also about Texas, about the town of Texarkana, which, as it's for people who don't know Texas, as the name suggests, is on the Texas-Arkansas border. I guess they ran out of names, and so they just mushed together the two states in the name. And how there was a really fascinating measles outbreak there, gosh, 50 years ago?
Yeah. So this happened in 1970. So Texarkana is set up. It's sort of one city, but it's sort of two cities. There's Texarkana, Texas, and Texarkana, Arkansas, and State Line Avenue runs right down the middle. And at that time, kids were zoned for schools on the side of State Line Avenue that they lived. So if you lived on the Texas side, you went to a Texas school, and the opposite was true as well. But there was tons of mixing of the two populations. People would sometimes go to church on the other side of the border. There were stores where people would cross the border to go there. So it's not like they were separate populations. The difference between the two states at the time was that in Texas, there were not school mandates for measles vaccines, and there were not sort of government-funded pushes to get people to vaccinate, like vaccine drives that were funded by the local government. That didn't happen on the Texas side, but both of those things did happen on the Arkansas side. And so the MMR vaccination rate for, I guess it was just the measles vaccination rate, we didn't have MMR by then, but on the Texas side of the border was about 60%, and on the Arkansas side of the border was about 95%. And so what happened was when they looked at the end of the outbreak at where the cases lived, about 95 or 96% of the cases lived on the Texas side of the border. And so it was this just striking map in the article about this outbreak where this political line, it wasn't a mountain range separating them. It was just a street, and it was easy to cross the street. But because the policies were different on either side, it affected children's health. And that was, I think, eye-opening for me.
But is that still the case? Like, are there differences in Texas and Arkansas that would still make Texarkana sort of an object lesson in measles control?
Absolutely. So we saw this, and I have to give credit to Jonathan Metzl and his incredible book, Dying of Whiteness, for this example, which was that, if you look at the difference in taking or not taking Medicaid expansion, you see a very similar thing where the health of the two sides of State Line Avenue are quite different, and that was on the basis of whether the state accepted or did not accept Medicaid expansion as part of the Affordable Care Act. So you still see these incredible relationships between geography, but really political geography, and health outcomes.
So I think that's a theme all through the book, right? Sure. That measles is itself a disease, but it's also not exactly a metaphor, maybe a synecdoche for the larger weaknesses in public health.
Yeah, and there's a biological reason for that. I mean, it's, I talk about measles being a bellwether, being, an early warning sign, and that's kind of baked into measles biology, because measles is the most contagious virus we know. It is more contagious than flu or COVID or polio or Ebola, anything you can think of. And the other piece of measles is that we have an incredible vaccine against it. So you mentioned, 97% protection with 2 doses. And so when we see measles outbreaks, especially in a country like ours where we have in the past controlled the spread of measles, that is a warning sign. that is that is shining a light on a place where vaccination rates are low, likely trust in public health is low, and it's telling you, hey, you have to deal with measles right here, but also that there are other vaccine preventable diseases coming.
So a month ago, Caitlin Rivers from Johns Hopkins came to talk to us about her brand new book, A Crisis Averted, which is superb. And one of the things that she talked about that I found so fascinating is a periodic cycle of panic and neglect in public health. That something arises and we rush to worry about it, and maybe we send funding in its direction. And then as soon as the presumed outbreak or threat is over, the funding goes away and the attention goes away. And you describe a similar phenomenon and of our forgetting how important measles is. And there's a lovely parallel that you describe in the book to what measles itself does to the immune system, as well as to what it does to our collective memory of disease.
Yeah, so I agree, and Caitlin's book is fantastic. Everyone should read it. And I think that she was talking about problems in public health writ large, and I was saying a very similar thing specifically about vaccine preventable diseases, where one of the chapters in the book is called Making Nothing Happen, because that is what vaccines do. When vaccines work, when everything goes right, kids just get to grow up and they don't get sick, and you don't know who you helped. You don't know which child would have died of diphtheria if they hadn't gotten their diphtheria vaccine. When we look at a population, we can say, we've prevented X number of deaths, but you don't get to know that at the level of the individual child. Mm-hmm. And what happens is that these diseases get less common. And understandably, we have people who grow up, and then we have parents who have never seen any of these diseases or encountered anyone. So if you look back to, when the polio vaccine came out, there was tremendous excitement about the polio vaccine. Everyone knew how dangerous polio was. But now, if you talk to parents, people don't know people who've had polio. They certainly didn't, the people who are parents now certainly didn't live through, the fear of polio. And we see that with measles, where it used to be something that was more, it was a routine part of childhood, but it also was associated with, periodic deaths and really severe cases. And that thread has been lost. And if you talk to parents now, as I have, even parents who've had their kids hospitalized with measles, that they will say, I had never known anyone with measles. I had no idea it could be this bad.
Mm. So we're going to get to polio, because I think that's a fascinating contrast to measles. But I do want to ask first, I want to make sure that people know that this book is also a history of measles for covering a good portion of civilization. And the episodes you talk about in which measles really was a profound shaper of human history and settlement and exploration was really quite moving to me. I just wondered could you talk about that for a minute?
Sure. I mean, I think this was, I think, the thing that I understood on a deep level at the end of my doing research for the book that I did not understand at all when I went into it. And it's this relationship between measles and colonialism and poverty and racism and war. And so you look back to when the colonists came to Mesoamerica, and people do talk about smallpox as a cause of disease that they brought with them. It was overlapping outbreaks of smallpox and measles that decimated populations, along with the fact, of course, that the people who were coming over with those diseases were trying to topple the societies that they came into contact with. There are these island outbreaks of measles where Fiji was annexed by the British Empire in the 1870s, and very shortly thereafter, because there was increased contact between British ships and other British colonies and Fiji, measles came to the island for the first time, and over the course of months killed a quarter of the population. And when you have a population that hasn't experienced measles, and all of a sudden you have this introduction, and it's coupled with economic repression and with often with malnutrition and with colonialism, it is a recipe for a huge number of deaths. And so I think that is a theme that we have seen again and again and again. And one of the reasons that measles is, in some populations just consider, it's not a big deal at all, is, you look at the story of measles in like New York City, where I live, in around the turn of the century, the 1800s into the 1900s. And if you were a rich child and you were in a large house and you had great airflow in the house and you had someone to take care of you, you generally did fine. If you look at the kids in the tenements where they were crowded, they got exposed to measles at higher doses at earlier ages when complications are more common, then the death rates were much higher. The rates of severe outcomes were much worse.
When people say we're headed toward a new Gilded Age, the tenements of, I'm from Brooklyn,
Yeah.
the tenements of the Lower East Side are what I think of. And you talk very movingly in the book about some of that history and some of the early muckraking that exposed not just the conditions of poverty in the tenements, but specifically how measles was playing a role there. But I want to go back to polio because I remember in writing about polio, I read a bunch of the archival sources of what happened when the polio vaccine was announced in the early 1950s, and how dramatic that day was. It was a time when very few people had televisions, but there were televisions for sale in department stores and hardware stores, and people ran in from the sidewalk to look at it on TV or to listen to the radio. And there are accounts of people, women certainly, but also men, just crying on the sidewalk because this was the fact that the polio vaccine now existed, that polio might be ended, meant that their children would be safe, but also that society would be profoundly different. And that is both, as someone who's interested in vaccines and their effect, that is both a lovely story to me, but it's also very interesting that the measles vaccine, barely 10 years later, was not welcomed in the same way. And you have some very interesting analysis of the mistakes that were made at the policy and public health levels that kind of undermined measles vaccine. So talk about that.
Yeah, I think that difference is really important, and it also foreshadows what happened with the COVID vaccines, which I know that we'll get to. But yeah, I mean, the polio vaccine was this, incredible moment when the results of the Salk trial were announced and the vaccine worked, and people felt this incredible relief, and that is wonderful. That's how it should be, and that's what it was. It provided protection against something that was horrible. And the main policy decision at that point was really around how do we get this vaccine into as many children as possible, as fast as possible, because there was essentially no vaccine hesitancy about the polio vaccine. Like, people were falling over themselves to get their children this vaccine. And one of the things that happened at that point was they had to figure out how to pay for it. There were the logistics, and then they had to figure out how to distribute the polio vaccine. And that ended up requiring some private funding. So the March of Dimes was important in that, and also some public funding. And Eisenhower had to be talked into it, but there was federal financing for polio vaccine rollout. And the contrast to what happened with the measles vaccine, which was just as much a scientific triumph, and is should have been greeted with excitement, it really wasn't. There were a couple of reasons for that. So the first is that the messaging was, I was going to say suboptimal. That might be too kind. 2 measles vaccines were licensed in 1963 at the same time on the same day. They were announced by the Surgeon General. One of them was the live attenuated vaccine that we essentially still use today. We use a derivative of that vaccine as the measles part of the MMR combination vaccine. And the other was a killed virus vaccine. So it's sort of like the Salk versus Sabin polio vaccines. And They were both licensed for use. There was a preferential recommendation for the live attenuated because even the early data suggested that the live attenuated worked better. The problem was there were more side effects with the live attenuated. About half of kids got fever. You actually needed 2 shots at the time that you got the vaccine because you had to get the vaccine and then in the other arm a dose of gamma globulin to decrease the side effects. And it was confusing for parents and it was confusing for doctors. And, because parents on hearing this would be like, well, why can't I have the one with fewer side effects? And the answer was, it doesn't work as well, but then why are you licensing it? So it was confusing for both parents and doctors. And the financing part did not come through. There was, the idea was, oh, people can just, parents can just bring their kids to their doctor to get a measles vaccine. And the problem was that they were expensive. There was about $10 a dose for a measles vaccine, which is about $100 a dose today. And there was no governmental support for them. There could be some local support, but there wasn't federal support for them. And so, one of the issues that stemmed from that was that it widened disparities. Like measles always has caused worse disease, more death, more severe disease in poor children. And in this case, now you're giving protection to the kids whose families can afford it and not to the other kids. And so this all eventually got fixed from a policy point of view, but it took a very long time.
It's fascinating to me to look at the history of vaccination in the US since then and see how many of the major pieces of policy that still exist with regard to vaccine kind of come from the measles vaccine introduction or fixing the measles vaccine introduction. But to skid over all of those, because we were already more than halfway through the hour and loads of people are asking questions.
Great.
There's one other thing, there's 2 other things that I think we should talk about, but we may want to push one of them off. You raised the issue of COVID and what the COVID vaccine rollout was like and how complicated that was. And I do think we should talk about that in the setting of measles. But in between the measles vaccine and the COVID vaccine comes the start of the anti-vaccine movement.
Yeah.
Is now the time to talk about that?
Sure. It's always time to talk about that. Yeah, I mean, there have been people with questions and people with doubts about vaccines for as long as there have been vaccines. Like if you look back to smallpox vaccine and there are the cartoons of someone getting, because it's cowpox, someone turning into a cow when they get the smallpox vaccine. So some amount of skepticism has always been there, and that's fine. That really kicked into higher gear in the 1970s when there were some small studies, some case series really from England that suggested that there were adverse effects of the DPT vaccine, the diphtheria, pertussis, and tetanus vaccine. That was, those concerns were amplified in a TV show in the United States, and so there was pushback against those vaccines. It wasn't at nearly the scale that we're dealing with now, but it was enough that rates of pertussis went up because vaccination rates went down. And then, the main thing and the thing that's relevant to measles vaccine is in the late 90s, there was the fraudulent and highly conflicted paper from Andrew Wakefield, which described a small series of, I think it was 12 children who he claimed developed a regressive neurological disease, a kind of autism that was linked to the measles component of the MMR vaccine. This was, he was paid by plaintiff lawyers to do the study, to find what he found. He had filed patents that were not disclosed for separate measles, mumps, and rubella vaccines. So this has been done in great detail by Brian Deere in his incredible book, which is The Doctor Who Fooled the World. But that was really, I think, the birth of the real pushback against the measles vaccine, the MMR vaccine, and the idea that those vaccines might be linked to autism has proven to be just incredibly sticky. Like it is. And I think that is that it's this simple concept. It's a 3-word thing, right? Vaccines cause autism. And it's easy for people to understand. It's easy to remember. And it deals with a condition, autism, where there is no easy answer. If a parent goes to their pediatrician and very reasonably asks, well, then what does cause autism if it's not vaccines? A good pediatrician will say, well, there are some genetic causes of autism. There are some environmental causes of autism. There are some infections that cause autism. Congenital rubella is a big cause of autism. Many, many cases of autism don't have a known cause. And that's a long answer. That's not a 3-word answer, and it's not a satisfying answer. And I think it is hard to compete with the other side on that. And it doesn't matter that so many studies have been done that debunk the MMR autism connection. So that his study was 12 kids, and there are studies with tens of thousands of kids on multiple continents, and we can definitively say there is no link between the MMR vaccine and autism. But I don't think that matters to a lot of people.
So you describe in the last sort of third of the book the rise of the vaccine hesitancy, anti-vaccine, vaccine questioning movement, and how from that Wakefield paper it has become extremely prevalent and challenged a lot of policies. And a name that surfaces about 2/3 of the way through the book as a vaccine questioning advocate is Robert F. Kennedy Jr., who was pushed back on vaccines long before he became HHS secretary and now is the head of the health agencies of the United States. Would you like to say something about that?
There's so many things I'd like to say, but it's a family show. Yeah, I mean, this is a very worrisome situation, and I think you've heard this, on the news from many of my colleagues. This is something we've talked about for a long time. I think that the RFK confirmation hearings were very concerning. He said what he needed to say to get the position, but it's he has spent the bulk of his adult life fighting against vaccines, stoking fears of vaccines. He has said that there is no such thing as a safe and effective vaccine. He, in particular, thinks that measles is a benign disease, and said so today after the tragic death. That was his response to the tragic death of this child in Texas was, well, measles outbreaks happen. We have measles outbreaks every year. We don't have children who die of measles every year. Right? Like it's been since 2003 in the United States since a child died. There was a death of an adult in 2015. So that's the 10 years ago one that people are talking about. But I am worried, and I think we are already seeing the downstream effects of RFK in that position where CDC is cut off from the global health world. We're unable to have meetings of advisory committees that are important. It's a frightening time.
So when we started talking, you made some reference to this major measles outbreak in New York before COVID, 2018 and 2019, centered in a I don't know if it's correct to say a particular religious community, or maybe several religious communities, and it just sort of blew up the statistics on measles in New York.
Yeah.
But one of the things that I found really interesting that you go into some detail about is within that outbreak, instances where there were successful strategies for dismantling or peeling away people's vaccine hesitancy. And I would love to hear you talk about that and how you observed it, because on the one hand, it sounds like a solution. On the other hand, it sounded awfully labor intensive.
Yeah, and that's the problem. And I will quote one of my mentors, Paul Offit, who has said many times over the years, it is easier to scare people than to unscare them. And in the same way, it is easier to flood the zone, for lack of a better term, with misinformation and disinformation than it is to give people good information and make sure that that's what they're accessing. And so it's, so during that outbreak, which was centered in an Orthodox Jewish community in Brooklyn, there was messaging from the New York City Department of Health, and they are wonderful, and dedicated people in the DOH. They were operating with several disadvantages, one of which was there was tremendous distrust of the DOH in that community that predated measles and stemmed from issues that initially had nothing to do with measles or other vaccines, but vaccine hesitancy was partially a casualty of that mistrust, and it definitely hampered the ability of the DOH to effectively communicate with the community. Which isn't to say that they didn't do vaccine drives and get people vaccinated. They did wonderful things. But the thing that I think really made progress was that there was this group of Orthodox Jewish nurses led by an incredible woman named Blima Marcus, who I have now over the years become friends with, and she is just wonderful. And she organized this group of nurses. They went from house to house, one family at a time. Sometimes they would have small groups. They would sit, they would speak to them about vaccines. They would ask what they had heard. They would debunk things gently. They would go through studies. They would show them how to read a scientific study. They would look at graphs. If parents were going to, were on the fence or they decided to vaccinate their child, she would text them on the morning they were going to get them vaccinated and say, I'm thinking of you, it's great you made this decision. She'd text them afterwards and say, how are you doing? It's this sort of multi-touch thing from a member of the community who was trusted, and that worked. It's, the problem is, as you alluded to, how do you scale that? How do you scale that to just, to combat just massive vaccine disinformation all over the internet? I mean, we, those of us who are trying to push back against it, try to put out good information, and that's important. It's important for the good information to be out there, but it can also very easily be drowned out. And I think that local organizing of some kind, and some of that is the relationship between individual families and their pediatrician or another family doctor, like that is helpful, but there has to be that connection that's there, or I think you don't make progress.
So to return to the Texas outbreak, are there lessons from things that went on in the campaign that you've just described that could be applied, do you think, to the Texas outbreak, where, as you said, there's, on the one hand, there's a very established Mennonite population. On the other hand, there's also a very large, because of where it is in Texas, there's a very large Latino population. Sure. Who may have different reasons for viewing government approaches with skepticism or distrust. So what for something like this, especially in an outbreak that is large and appears to be growing, I understand you're an outsider, you're not in Texas, but what would your lessons be for how locally to approach that?
Right. I think there has to be sort of the traditional public health approach. Of course, you have to make vaccines available to people. You have to put out information that says vaccines are safe. That's how you prevent measles from happening. That's how you protect your children. I would speak to the local pediatricians or family doctors in the community and try to enlist them also, because I think that, as a pediatrician, I still like to think that the relationship between a pediatrician and a family, even a family who is very vaccine hesitant or even anti-vaccine, I think most of those families still value, at least to some extent, what someone who has devoted their life to understanding children and helping them stay well has to say. They may not agree with it, but they may be willing to engage in that dialogue. And I think you have to find that. There's some precedent for having local religious leaders or others, step in and say, this situation is different. We need to act differently here. There was some of that in the 2019 New York City outbreak. It didn't work as well as we hoped that it would. And so I think a lot of it is just particular to the specific communities that you're dealing with. And so you need to partner with people and understand. I don't think, having never been to Gaines County, I don't think I could possibly understand what what the single right approach would be.
So obviously we've been, throughout this chat, we've been popping up questions from people who are watching, all of whom have had lots to say. Their questions have been very relevant to the things you've been saying. And there's one other one that I want to call out. Well, there may be a couple more, but this one really raises the issue of stigma, of how, is it a problem that the Texas outbreak is being reported all over the country with a great deal of alarm, and it's becoming an issue, like an issue with the new cabinet, with RFK Jr. and so forth. Is there a way that we should be asking the media to approach this outbreak differently to keep from stigmatizing people so much?
Yeah, I agree that you don't want to stigmatize people. It's hard though, because you do want people across the country to understand what's going on, to understand that measles isn't a solved problem, that it's not, that children can die from measles. Like it is horrible that there is a grieving family and that they know that their grief is being, broadcast all over the country. I agree, that's not optimal, but it's also, that is something that it is important to get the word out about. I worry about that too, and I think we worried about that a lot with the Orthodox population here. You don't want this to turn into something where people are turning against that community because they had low vaccination rates. That is not a recipe for making things better in the future. That's a recipe for pulling people apart.
So let's talk about the future. What do you think the trajectory of measles and of public health is from here?
Yeah, I mean, I can talk about the U.S. and then I can speak a little more globally than that. I'm really concerned on both levels. Like I think that even before COVID, our vaccination levels were dropping. So we want that 95% for kindergarten MMR. We were above that prior to COVID. There were drops in vaccine coverage during COVID all over the world because systems were disrupted. And then in the US, at least, they mostly rebounded, but we never got back to where we were. And we're now in a situation where the nationwide level, which is, doesn't have the granularity that you need, but is at least a marker of how we are feeling about vaccines as a country, is under 93%, and it's falling. And that is concerning, and because we are always, even since elimination in 2000, there have always been some cases of measles. People travel, they come back. And so what happens downstream of that depends on the wall of immunity that you've built. And it's, that wall is decreasing in strength. And so I think we will end up seeing, instead of lots of small outbreaks that sort of burn themselves out, more sort of medium-sized and large outbreaks like the one that we're seeing in Texas now. And that is, we're seeing what can happen in those outbreaks. Like you can have children hospitalized and children die, and there are long-term effects of measles that are frightening as well. But I think that it's, as you alluded to, it's not just going to be Texas. It is going to be in many places.
So you said you'd talk about the global situation as well.
Oh, I did.
And I remember when I was traveling around with polio eradication teams in South Asia, that public health planners would say, we're going to get polio done and measles is going to be next. And they were already in their heads and in their notes constructing a measles eradication campaign for the world.
It can be done. Yeah, I mean, it can be done. It's a choice. I think we've had tremendous setbacks in the last couple of months. When I wrote the book and I got to the end and I'm talking about measles eradication, I did not think that we would be in the situation that we are in right now, where I'm worried about dropping vaccination rates in the US, and that those will continue to drop. And with the dismantling of the US's involvement in global health, I think that we will lose progress on measles control in places where it was controlled. I'm worried about the polio eradication campaign for the same reason. And that is tragic. But it has to remain a goal. Like, I think that measles eradication would be an incredible achievement. It would be amazing science. It would benefit the children of the world. We would be able eventually to stop vaccinating against measles the same way we stopped vaccinating against smallpox. It's going to, like smallpox, it's going to require investment and multinational collaboration and all sorts of things that it doesn't seem like we're headed towards now.
So in the last chapter of the book, you execute a lovely sort of spin on your title, and we all understand that booster shots means a vaccine when we come to the book, but in the last pages, you talk about booster shots in a sort of non-physical way, that we need booster shots of our belief in vaccines, of our understanding of the context in which vaccines are delivered, and our commitment to continuing to deliver them. So I would love to hear you talk about that, because I think where we need to end this conversation is for you to give us some hope.
Yes, I will try. Booster shots are about memory. What a vaccine does is you give a child a vaccine, their immune system recognizes it, it forms memory cells that then can be called into action if the child ever encounters the real pathogen, the real measles virus, the real flu virus. And that is important. And sometimes, less with measles than with other things, but sometimes over time immunity wanes and people need booster shots to sort of reprime that memory. And we see that with COVID. There are some other vaccines. You need a tetanus booster every 10 years. Same sort of thing. And I was thinking about that in the context of forgetting and what we were talking about, where when you vaccinate and these once common diseases become rare, we forget. We have parents who've never seen measles or polio or whatever, and the stories are lost, and the fear that people feel is lost, and they question whether it's worth vaccinating against these things. And I think that part of what we need to do is communicate about these diseases in a way that is meaningful to people and accessible to people. And some of that is talking about the history of science and the history of public health. Some of that is owning up to when we've done things poorly. And there's plenty of that to talk about. I talk in the book about some unethical experiments. I talk about missteps during COVID. I think that COVID vaccine development and rollout and everything else is a tremendous scientific accomplishment and just a triumph. Like we did something that had never been done before. It saved tens of millions of lives. That's not how it's remembered by most people, and that is worrisome, because I think that could have been a moment where public health really shined, and it could have been really bad for the anti-vaccine movement, because people would have seen a pandemic develop, a vaccine be developed and rolled out, and then a return to normal life. But that's not the narrative that's out there. And I think that's the kind of thing where we have to give people reminders and teach about what we know, because we have the tools to do so many amazing things. Like, it's not like these kids in Texas are getting measles because we don't have a measles vaccine. And so I think that kind of storytelling and that kind of a different kind of boosting is really important.
So what I want to tease out in our very last couple of minutes is sort of your call to action for the people who are listening to us and have been such an engaged audience. Thank you, everyone who's commented. I'm sorry I can't get to all your questions. I don't think we've ever had so many questions in one of these live streams before. So you know, when you say we, that we could do this, we ought to commit to this, that could be interpreted as we, um, meaning people like you, the professional class, the public health class, the medical class. But are there things that you want to see sort of average people
Yeah,
do?
absolutely. You know, I mean much more than me. It's no, I think that there is this really vocal anti-vaccine, anti-science group out there, and they have one of their own in charge now, and that is a frightening situation. But I really do think that local communication that takes place off of Facebook or Instagram or whatever is really important. One of the things that people can do is normalize getting their kids vaccinated. Most people get their kids vaccinated according to the normal schedule, the AAP and CDC recommended schedule. Caitlin Rivers just had an op-ed about that in the New York Times. She's 100% right. I don't know. Tell your friends when you get your kids vaccinated, or when you go get your flu shot or something like that. I would normalize that, because the other side of things is so active in putting out bad information that sometimes it can feel like it's an uphill battle. But I think just those conversations with family, and engage with your anti-vaccine relatives. Don't shun them, but talk to them. And I think that people really do care about what the people they love think. And these are hard conversations, and they are usually not just one conversation. And it's not one person's job to convince their anti-vax aunt to vaccinate their kids, but it's you can gently push, you can gently ask, and that little bit helps. And I think that building community, whatever that means to you in your community, is important. I think that's how we resist bad information. So I think all of those things.
That was great advice. Thank you so much. And thank you for bringing what you were saying back to the whole purpose of this series, which is health storytelling. So thank you for recommending that. And thank you so much for coming tonight.
Oh, it was my pleasure. This is fantastic.
So that's it for this edition of the Health Storytelling Author Q&A series. Please consider following Adam on social media. He is Adam Ratner, MD, on Blue Sky and Threads, and he's also still on Twitter or X, which makes him a braver social media person than I am. And please buy his book, which is available at Penguin Random House, his publisher, and at Amazon, of course. And lately, we like to promote bookshop.org, which is the anti-Amazon because it funnels profits and support to local bookstores. Please join us next month on March 19th to hear from best-selling science writer Carl Zimmer and his brand new book, Airborne: The Hidden History of the Life We Breathe. That's a co-production with the Atlanta Science Festival. Visit our RSVP page to sign up in advance for Carl's live stream, and also Jaap de Rode in April. All of the episodes of this series, 4 or 5 years, including tonight's, are archived there on YouTube. And until next time, I'm Maryn McKenna. On behalf of the Center for the Study of Human Health at Emory University, the Georgia Center for the Book, Emory's Center for Public Scholarship and Engagement, Ideas Festival Emory, and the Atlanta Science Festival, and from me, thank you for watching. See you next month.